So thank you everyone for coming. I know more people are joining. Like I said, we have over 100 people that have signed up to come today. But welcome, welcome, welcome. And first I'd like to tell everyone that the Q&A, there's a little tab called Q&A at the bottom of your screen, and that's where you should put any questions that you have for Dr. Bailey or Dr. Asghar. So we'll get to those at the end of the presentation, and we have timed the presentation so that it's shorter than the hour, so we get time for Q&A. The chat is for you, for the audience, to talk to each other, tell each other where you're from. We'd love to see in the chat, where you're hailing from. And we have folks like Stephen and others who are looking at the chat and who can engage with you. So feel free to talk about the presentations today and to each other in the chat. And if you have questions for Dr. Bailey or Dr. Asghar, put them in the Q&A. By way of introduction, I'm Julie Lemoyne. I'm the moderator of this wonderful talk. I have been working in applied XR for more than 15 years, and I've worked with over 25 different companies and organizations and educational institutions in different sectors. But maybe more interestingly, I am just about to finish a PhD in applied XR in health and well-being, and I'm working at the University of Massachusetts Medical School with their Shriver Center, who supports families and individuals with autism. And I'm an Irish Research Council scholar sponsored by Microsoft in this area. It's mainly AR that I work in for my PhD. But let me tell you a little bit about MedVR as we get started here, because it's a new organization, new in 2020. It's a community centered around knowledge sharing about and developing new applications that use augmented, virtual, mixed reality and 3D gaming and that type of technology. And our mission is to seed community and a community that's cross-sectional, so comprising healthcare professionals of all types, along with scientists and developers and designers and technologists and artists, and other experts, in addition to the end users who will receive benefit from this type of technology in healthcare. So this year in 2020, we have presented 12 webinars. I don't know if anyone else was counting, but since I moderated most of them, I was counting. So in 2021, we plan to offer an educational curriculum that can be followed to increase your knowledge in the field. And as the pandemic permits and other things permit, we plan to hold a hackathon in 2021. So our goals as an organization really are aimed at growing this unique and very diverse community over the coming years by sharing expertise and knowledge. So none of this happens, let me go to my next slide, without some help. So if your organization would like to sponsor MedVR or are interested in getting involved, please reach out to us. And you can learn more about MedVR and our team and our online programs at medvr.io. So let me just take it back on my slides. I will go up. So it is my great pleasure today to introduce a couple of trailblazers, 2-3 trailblazers. We'll see who can make it if Dr. Asghar can make it, who are working in the area in medicine in VR of the use of live stereoscopic video within VR for remote training for surgical experts and for sharing surgical expertise. And I think that's just the beginning. That's just the tip of the iceberg for where they're going with some of their capabilities. So let me just introduce the pioneers and we'll get the talk going. So first, I would like to introduce Dr. Shannon Bailey. Hi, Dr. Bailey. Dr. Bailey earned her PhD in human factors and cognitive psychology from the University of Central Florida and has more than 10 years of experience designing and testing training simulations in educational games. So I know everybody in the audience is like, oh boy, I could use someone like that on my team. And Dr. Bailey's research examines effective instructional training in virtual reality, adaptive training, game-based simulations, and natural user interfaces. She's been in peer-reviewed publications in journals such as Human Factors and Cognitive Processing. She's a co-author of a chapter in a book and has been an award-winning proceedings paper writer on training effectiveness and received the 2016 RADM Lewis Inter-Service Industry Training Simulation Educational Award. So she hasn't been doing much. So wonderful to have you. Thank you very, very much for coming. And we have Dr. John Asghar, who is not Michelle wearing the antlers, although you look awesome, Michelle. Thank you very much. He is with a patient right now, and he'll be coming in time to give his talk. Just to let you understand Dr. Asghar's background, which is amazing as well. He is a fellowship-trained spine surgeon specializing in the research, education, and clinical studies of pediatric, adolescent, and adult scoliosis. He's an orthopedic spine surgeon at the Paley Orthopedic and Spine Institute that is affiliated with St. Mary's Medical Center and Holy Cross Hospital. He's a thought leader and continuously embracing the latest advanced technology breakthroughs to improve the lives of his patients with complex spinal deformations. And the really important part to add to that is that he shares his expertise and his new techniques with other surgeons, which is what brought him together with Dr. Bailey from Immertec in order to use their technology. And in case Dr. Asghar cannot come, we have Dr. Richard Freiland on deck. But I think that Dr. Asghar is going to be able to make it. So we just want to thank Dr. Freiland for offering to come in Dr. Asghar's stead, just in case. And he is the Vice President of Training and Education at Immertec too, and has a very long career, including things like heading up the Executive Director of the Captain Medical Program too. So we have somebody back up just in case Dr. Asghar gets taken away by his patients, although we believe he will make it today. So I would like to remind you to please put your questions, if you have them during this talk, for the doctors or myself, whatever question you have that you want to talk about after the talk in the Q&A. So just click the Q&A when you have a question for the doctor that's speaking, and then we'll go over those. We'll go over, I'll go over as many as we can in the time permitting, other than, hey, I want a job. So we probably won't cover those questions. So feel free to put those in chat. And you can probably reach out to the doctors, out of band for that kind of interaction. So with so much trailblazing brilliance, we do want to sort of chunk up the top so we get to cover each part that we wanted to cover. So what we've done is we've decided with the doctors that the first 10 minutes, Dr. Bailey is going to talk about insightful background, like what's been happening with VR that has influenced Immertec or has prompted Immertec to do the work that they're doing in live stereoscopic video within VR. And then Dr. Bailey is going to talk about how they created and why they created the technology that they did. And exciting for all of us, particularly me, is she's going to talk a lot about the human factors side and on the testing and validating from a medical context, which is something that I don't think MedVR, we haven't presented anything in the video with VR before today, and the human factors part is so important. The final 30 minutes, Dr. Asghar is going to discuss how he's using their capability to share techniques with other surgeons and experts. And then also he is starting to work through how he's going to measure the outcomes of this type of training. So we're going to hear from him about that as well. And then we're going to go into Q&A. I'll kick it off with a few questions. And I have a little bit of thank yous and sort of housekeeping to do at the end, and then we'll open it up to the questions from the audience. So I hope that makes a lot of sense to everyone out there. And it looks like we're up to 50. So I know we're cranking up to the hundreds that are signed up, but I think maybe without further ado, I'm going to hand it over to Dr. Bailey. Let me let go of my screen share.
Okay, and let me start my screen share.
Fantastic. So again, a reminder, use the chat if you want to talk to the other attendees, and use the Q&A if you want to put a question in for the doctors. And you have the floor.
Okay, and you can see and hear me?
We can.
Okay,
fantastic.
Great. Okay, so first, thank you for having me today. I'm going to be talking about live streaming video in XR for remote medical education. I do want to give the caveat that I'm going to be using the term virtual reality and VR a lot, but a lot of what I'm talking about fits in the spectrum of AR, VR, XR, so don't get too caught up in the terms. Okay, so first I always like to start with an overview so that everyone's sharing the same mental model for the presentation, but Julie covered a lot of it. Very briefly, my background is human factors. I'm going to be talking about what's been done before in terms of VR and healthcare, mostly to give context for the system that I'm going to be describing today, which is the stereoscopic video training that we're doing. So then I'll go into what we're doing now, Immertec's approach to remote physician training, and then go into why we're doing that. So I'm going to dive deep into the scientific theory supporting live stereoscopic video, and then follow that with how we're validating that with two different sides to the research, which is the development validation and then the evaluation with the system out in use. So super briefly, because Julie mentioned a lot of this already, my background is a PhD in human factors and cognitive psychology. The human factors is making technology safer and easier to use. The cognitive psychology is the study of how people think and learn. So I combine these for the past 10 years in designing and testing simulation trainers with the goal of figuring out, is the system effective before it's in use? So I'm going to go high level with the current uses of VR in healthcare because there are many great talks from MedVR and others talking about the specific use cases of VR in healthcare that go a lot deeper than this. This is to give some context about what we're doing here, because when I talk about saying that I work with physicians on a virtual reality trainer, a lot of them think that I'm talking about game engine environments because a lot of previous work in VR for medical training and healthcare training has been done with game engine simulations. So these are worlds developed in Unity or Unreal Engine, and they're 3D models of a real environment, such as the ACLS training you see there, where they're in the simulated hospital room, or surgeon trainings where they're using 3D models in virtual reality. So a lot of people think of VR as being game engine based, but we are actually video based virtual reality. There is some use of this previously with recorded video in virtual reality. So this is an example of a 360-degree video that was developed so that patients could experience what it's like to be going into for a procedure before they get there, just to get them more comfortable with the experience before they get there. So what is 360-degree video? So usually when people are talking about VR video, they're usually referring to 360-degree video, which is a camera that has lenses in a 360-degree configuration, and it takes a picture of or a video of the actual location, and then the person who's viewing that in a headset, they see the 360-degree around them of the image. What's important to note here is that usually this is a 2D flat image that's projected around the viewer. And I want to make this distinction here between the monoscopic lenses and the stereoscopic lenses, because this is important for the research that we're doing later on. So a lot of times when people think of 360 video, they're really thinking of monoscopic video. That's a flat image around you, which is two-dimensional and lacking depth. Stereoscopic, in contrast, is instead of one image, they're combining a left and a right image, similar to how the eyes combine a left and right image to create a sense of depth. So when the image is stitched together, you get more of a sense of depth, where if you look left and right, the image changes so you can see the depth associated with the video that you're seeing. So a lot of what I was talking about before was with recorded videos in medical education and in the medical field in general. A lot of live streaming that does exist out there. There are limited options for live streaming in VR, but that does exist are typically done in the entertainment industry. So sports games and concerts, those are typically where you see live streaming with VR, both 360, monoscopic and stereoscopic, though usually still monoscopic. The reason you don't see a lot of live streaming with VR is really the latency has been a hurdle historically. There are benefits to having recorded videos in VR. So these videos allow for post-production quality. You can have a video library if they're recorded of asynchronous instruction. But the disadvantages there are that it takes time to create these recordings and do the post-production, which really limits the ability for live interaction. Whereas if you're live streaming an event in virtual reality, you're able to see a live event. And if the latency is good enough, you're able to have a conversation with experts or peers remotely while you're watching a live video of an actual event. But there are limited options right now for streaming in VR. And those that do exist, the latency varies widely. So I cite a paper here from last year that looked into 360 live video streaming services, including YouTube's and Facebook's. And those, they found that the latency for one way from the broadcaster to the viewer was about 18 to 30 seconds, depending on the system. So if you're waiting 30 seconds, so 30 seconds there and 30 seconds back to have a conversation, a whole minute of delay really doesn't allow for a conversation to happen. So that's why I pointed out here, because the system that I'm talking about today, when I talk about live streaming, I'm not talking about a delay of a concert of 5 to 10 seconds or a delay of 360 video of 30 seconds. I'm talking about live streaming in real time that's under a second, so you can have that conversation back and forth. So I bring up all of this previous research to show what, in contrast, what Immertec is doing. So the system that I'm going to be talking about today, it's live video, so it's not a game engine based developed system. It's stereoscopic, so you get the sense of depth there with the video. It's low latency, where the round trip latency is under a second, and the time from what you see in the operating room to when you see it on a remote headset is under half a second. So when we're talking about low latency, this really allows for communication remotely between experts and peers. So now I'm going to get into specifically what is Immertec system doing, what does it look like? So currently we have systems in hospitals, bioskills labs, some simulation centers, and this is the cart that is streaming the stereoscopic video to give you an understanding of what it is that our system is doing. So from the hospital or operating room, there's a stereoscopic camera on the cart on an articulating arm. There's a streamer computer that's sending the stereoscopic video along with other medical imaging feeds. So if there's a scope feeds or CT scans or something that the operating room wants to send to the remote viewers, those are also streamed as overlays. Importantly, there's a speaker and a microphone. So this gives the ability for the operating room to speak back and forth with the remote participants. And then there's a monitor for the instructor. So the instructor can see who's attending. And they also, all of the controls, the capabilities rest with the operating room ultimately. So they choose what's sent, when it's sent, who's muted, and all of those features. So what does that look like from the remote participants' perspective? So physicians who are signing up to attend live events, they sign up for events on a mobile scheduling app. Once they're registered, they're sent a VR headset, which they then pair to their account, which allows them access to a live event. So when they put on the headset, they're able to attend that live event. And once they put on the headset, they get a VR, the VR headset, they're able to see the stereoscopic view of the operating room. They are able to move around or enlarge or shrink medical image feeds that they have there. They're able to see a list of other attendees. And there's, importantly, conferencing capabilities. So they're able to speak back and forth with under a second round trip latency to the operating room. And I have a quick video here. It's a 30-second video, well, 40-second video that shows one example from a previous training. Oops.
Dr. Lee is going to go and grab behind, and I'm going to take, I have a little traction stitch in, but I'm going to take that out. Take the traction stitch in.
Very good. Now, Mark, tell us about the configuration of the tear. Is it a reverse LL? Is it a crescent?
It is it's pretty much a crescent tear and with really poor quality tissue. That's why we have this rip stop right here. You can see that.
So I show this video because obviously it's 2D on this PowerPoint that I'm presenting today, but this would be a stereoscopic view of the bioskills lab or operating room. You're able to see the back and forth conferencing. The communication is real time. You're able to see the other feeds there. So there was an overhead camera that they were using and a scope feed, which the person who's watching remotely can move to where they want in their field of view and enlarge and shrink it. Also, I do want to point out that the only camera that's associated with our system is that you saw on the cart in the previous slide. All of this other equipment was for a different AV setup that day. So that's a thing that I wanted to clarify so there's not confusion. The system is the cart that I showed you earlier. So now I really want to get into a deep dive on the scientific context for why we're investigating XR training. What is it that makes XR training useful in a medical training context? So first, is there evidence that XR technology is useful for education and training? Broadly, yes. So a meta-analysis that came out this year found that across domains, XR training was as effective as other methods of training. And the authors specifically go into if the training is as effective as other methods, XR is particularly useful then if you can't provide experiences in real life. So XR is able to provide those experiences, give you options like for this year when travel or in-person instruction wasn't available, XR gives that option for that kind of experience. Additionally, there's evidence that VR is better than 2D displays for recall. So in one study, they found that there was 8% better recall, fewer mistakes, and participants felt more confident and reported feeling more spatial awareness when doing a task in VR versus 2D. But does this translate to healthcare education? A meta-analysis that came out last year found that VR was better than other digital education platforms for healthcare education, specifically for post-interventional knowledge and cognitive skills. Though the authors do point out that other outcomes there is limited evidence for, such as patient outcomes. So this gives the support showing that XR is something that should be looked at in medical education. We should investigate it more, but there's also more room in the research or in the literature for research that addresses these broad outcomes. So now I want to go into specifically what is it about immersive displays that make them effective for training. There's a big school of thought out there that presence is really important for that immersive displays give a sense of presence or a feeling of being there in the environment. So is it important to feel like you're in there in the operating room seeing a task or a procedure being performed? There's some evidence that immersive displays are better than 2D displays for learning skills. So this one study, they looked at medical school students with their not tying abilities, and they looked at 360 immersive video versus 2D displays, and they found that the 360 immersive video was better for learning. Additionally, something that I think is really important that can be addressed with the stereoscopic video is that you're presenting information, more information in 3D with the stereoscopic video. So there's more visual information with 3D, such as depth and orientation for learning spatial tasks. And it's been noted in the literature before that surgery is inherently spatial. So if you're learning a 3D task in 3D, it's less mental effort than translating information from 2D into 3D. So there's evidence for this that in a surgery trainer where they looked at a 2D versus a 3D display, they found that there was actually higher cognitive load for learning the surgery, the task in 2D versus 3D. So learning something in 3D that is 3D, you have to do less mental gymnastics, hold less, information in working memory than if you're trying to translate that information from 2D to 3D. But there are other potential mechanisms that might make immersive displays useful. For example, focused attention and limited distractions. If you're watching a 2D instruction like this webinar, you have the potential to be on your phone or have other tabs open. So there are other distractions, whereas if you have a VR headset on, you're focusing on the germane information of learning the task and not all the extraneous information that's not relevant to learning. Potentially also engagement or motivation could be increased with VR. There's some evidence for that. Really, this slide is to show that there is evidence that immersive displays are useful for learning, and these should be investigated so that we can really dive deep into what are the actual mechanisms underlying the benefits of VR in medical contexts. And then I also want to bring it back to telementoring has a lot of support in medical education. So telementoring is really mentorship when an expert is not located in the same place as the trainee. And telementoring is useful in these contexts where in-person isn't practical, but it also has high acceptance among physicians. So for example, dissemination of medical knowledge to rural areas is historically slow, but 80% of rural physicians surveyed thought telementoring would benefit their practice. So there is acceptance for telementoring. In addition to that, there is support that telementoring in the systematic review from last year, they found that telementoring was as effective as on-site mentoring in this review. And they go into the reasons for that. And one of the reasons that is cited in the literature is that observing an expert leads to better practice. So in the see one, do one, teach one model, seeing an expert modeling appropriate procedures and showing the expert mental model then helps the student later in the practice. So observing an expert is important. In addition, the synchronous education is important. So being able to communicate back and forth allows the expert in instruction. You can immediately respond to questions with live telementoring. However, the literature reviews do cite, or the reviews in the literature cite that there were limitations to these previous telementoring systems, which were mostly 2D video conferencing like Skype or Zoom. And that was limited resolution, limited field of view, and latency issues. And these are all issues that are addressed with the current system that we're looking at. So this brings us all back, summarizing literature. Why streaming live 3D video? We hypothesize that live stereoscopic video is beneficial for medical learning because it's a realistic patient case. We're not looking at a video game simulation. It's immersive, so you have the feeling of being there, and directed attention. It's stereoscopic, so you're getting more pertinent information in that 3D depth and other information that you're getting that you don't necessarily get with 2D. And it's real time, so you're real time observing and communicating with an expert mentor. So you're able to get that expert modeling, but also get the communication back and forth. And this is useful in cases where you want to see a live case, or the realism is important and that communication is important, but in person isn't practical or feasible. So I'm going to summarize with what is it, the research that we're doing from the human factors perspective. And this research is split up into two parts. There's the development research, and then there's the validation research. So first, I'll start with the development research from the human factors side. And it was really exciting as a human factor scientist to come in from the beginning and help to develop this system from the ground level with a human-centered approach. Because a lot of times human factors professionals are brought in after there's some user error or some disaster with the system, and they're brought in to fix it. But this system was designed from the beginning with a human in the loop model. So we started with interviews and feedback with dozens of surgeons and physicians and other medical professionals in order to refine the features and what this system actually should look like. We used an iterative interface design with user testing in order to test out each of these features. And one thing that was important was we created our own templates in 3D based on human perception or ergonomics to make sure that everything was placed in a way that made sense for the user, because a lot of times our user hasn't necessarily worn a virtual reality headset before. So when you ship them a headset and they put the VR headset on to watch a live event, you want that process to be as smooth as possible with as low of a learning curve as possible. And in order to test this from the development side, we conducted numerous usability tests, including usability tests with surgeons following trainings. And we also conducted both formal and informal tests with the general public on usability, comfort, and visual clarity in order to make sure that the system was user-friendly before it went out there to the surgeons. So now that the system is out there and use, we're focusing on the validation from a training effectiveness evaluation model. So the model of training effectiveness evaluation that we're using is a Kirkpatrick model. The reason we're using this model is it's a 4-factor model of training effectiveness. So it's not just saying people liked the training, so it's useful, it's a good trainer. We're looking at 4 different dimensions of training effectiveness. So we start with the reactions. So do people like the training? Do they find it useful? And then we also are looking into learning outcomes specifically with the system. So compared to other instructional techniques or systems, was there a measured knowledge gain, both immediate and retention? Another factor is transfer. So was the training useful on the job? And then finally, results at an organizational level. So these are, did the training lead to big organizational level results? So morale or cost or time savings. So these are all part of this training effectiveness model. Which leads to the training agenda that we have for this year and next year. So far, we've looked at the reactions components in this with our system. So we published a short report recently in Medical Education where ENT surgeons evaluated the VR system following a remote training. We've currently have under review another study with orthopedic surgeons where they tested our system, or they participated in a training event, and then they evaluated our system on a validated measure of usability. That way we can check the benchmark usability measures compared to industry standards. Additionally, we're currently working with 2 different medical schools, 2 universities that we have signed research agreements with to look at the learning outcomes. And this research is in preparation. We're conducting this very soon in the next few months. And then we're in the planning stages with teaching hospitals and medical device companies to look at these other training outcomes, such as the transfer and the results. So this is a summary of what we're doing, where it fits in the context of VR training, and how we're evaluating it, and the scientific support for these validation studies that we're doing. Next, I would like to bring on Dr. Jahangir Asghar, who is an adult pediatric spinal surgeon, to discuss his perspective on VR training.
Thank you, Shannon. So from my kind of adoption and kind of exposure to it. It started out very, we have two parts to what we do. Is basically I have a very device heavy job, a lot of screws, rods, instrumentation, navigation, a lot of technological development, and that transfer of the knowledge base for the technology is a very intensive process, and it a lot of times historically has been a very in-person process. And so the ability to transfer that knowledge base in an in-person way has been historically kind of how the information is disseminated. So ultimately, with COVID and a lot of the changes that are coming back down the pike, the cost of that and the feasibility of that has become more and more difficult. So having alternate ways to adopt, to train at the level of the medical student, the resident, and even in my case, a lot of times because of the specialty of what I do, at the level of surgeon practitioners, to be able to disseminate new technology is critical. And so a lot of what we end up doing and how we've applied it in our practice is twofold. We have a in-lab version of it, and then we have a in-surgical version of it. And the benefit of the surgical environment is a couple of things in terms of adoption. Is it gives you a stereoscopic view of the entire room, so you see how the room is set up. And from a surgical standpoint, it's not only oftentimes about the technical aspects of how you turn the widget, but it's a lot of times it's also how the room is set up to be able to place the widget. And that efficiency, kind of what we were talking, what was mentioned earlier, is critical in terms of ensuring appropriate adoption, because a lot of these things are they're what you can do in the lab and then what you can do in real life sometimes don't match. So being able to engage somebody in the lab setting where they're able to either through a proctoring or a reverse proctoring setup, being able to work in a lab setting, and then being able to experience what they saw in the lab in a live setting is critical in terms of kind of engaging the surgeons to really grow in terms of their knowledge base and their skill set to be able to do it. The other aspect we've been utilizing it for is product development. So product development is kind of a collaborative process, and a lot of times for what we do is it's usually done in an anatomic setting. There's a lab, there's things, and the ability to review technology and get experts from around the country together in one space. Sometimes that's a bit of a yeoman's effort. So this allows it to be done in a more efficient way. And it's actually been, we've done it a couple times now, where we've been able to get a lot of pretty heavy hitters in the same room, which is, unless there's something unusual going on, is pretty difficult. But we're able to do that and really kind of advance the technology, how we incorporate whatever widget that we're working on at that time. So for us, kind of it breaks up into different parts, right? There's the initial surgical training part, which is done, cadaveric training, cadaveric exposure, kind of the first step, and that is, the disseminating the knowledge. But ultimately, the goal is to get people to adopt the technologies that you're exposing them to, and a lot of times a single exposure in a lab setting isn't the best way to do that. So the beauty of utilizing AR, VR in this setting is now we can expose them again, in really close proximity in an intraoperative setting, and then from a kind of a nuts and bolts setting thing, they can see how the back table is set up. They can see how the surgeon places sets the room up, where the everything is, and then at the same time it can be very collaborative and interactive in a way that's pretty patient safe and appropriate, because we will a lot of times even I ended up, prior to the COVID thing, we would do a lot of visitations, and we would have an ongoing conversation with the visiting surgeons. This, when we've utilized it in that capacity, this hasn't been very much different. We often use the extra frames to have, especially for spine, we have a number of things going on. So we have our navigation system, which is coming up and live in one frame in the 2D frames, and then the other ones we have is electrical neuromonitoring to be able to show the health of the spinal cord function, and then PowerPoints or other things. And then during the process, the visiting surgeons can really engage in the process to be able to really learn and interact in a way where they're there. And sometimes it's even better because they're able to pull information very quickly that we have up that they may not have access to in the live setting. So that's been really nice in that set. Ultimately, anytime you have a new technology, I think the biggest issue around that is, one is adopting it. The second part of that is learning to optimize it. And this is where I am right now. I've gotten past the point of wanting to try it and know this is neat. Now we've gotten really to the point of the nitty gritty of how do I take the technology and turn it into something that we can get something positive from it. And so a lot of what we're doing now is, what frames do we want in the thing? How do we want to do the teaching part? How do we want to engage the visiting surgeon? How do we want to, at the same time, the issues that where we have our ENT procedures tend to be a little bit shorter in proximity. Spine procedures tend to be longer in proximity, right? They're a lot longer in length. And so planning out when you have the surgeons come in to engage, right? Because you can't have them on, the whole point is you can't have them on the whole 8 hours or 4 hours the procedure is. You want them on to turn towards the relevant time periods. And that's another aspect of it that we're trying to work through right now, is just really getting them to engage when they need to be on to the part that is most relevant for them, so they can go on with the rest of their day without really a lot of interruption in terms of the live surgical part. I think, it's been in a number of ways, we're really at the Paley Institute, I think a number of us have really taken to it quite and are quite excited about its potential. We're looking at even potentially utilizing it in some sort of conference setting, because a lot of times in conferences, we're not able to we want to be able to kind of rotate in live experiences, and this is a nice way to be able to do that in some of our conferences where we're having visiting surgeons from outside the area, where they're able to, again, in rooms you have, even in live settings, you have a limited number of surgeons that can actually physically observe. And so this allows us to have a larger number of people observe. And I think it's just been a really nice collaborative process to really grow and kind of really expand it out how do we teach other surgeons. Again, for me, the biggest issue right now is kind of learning how to make it optimal and making sure that my my visiting surgeons are thoroughly engaged. And then ultimately it's the adoption part. Like, do they walk away and do they feel like they've learned enough to take on or tackle the tasks that they've been exposed to? That's where I think for us, and I think that's kind of what the research aspect of it is where it is now, is how do we get surgeons to follow through on what they've learned in the lab setting, in the live setting, but now in a very different model than they've done before.
Wonderful. So I think you just about perfect timing, Dr. Asghar. So thank you very much. That was really, really insightful. I have to say that I keep thinking, when you were giving this whole description, I was thinking, but what is it like for you? Like, so it's really beneficial to the surgeons that you're training. Right. But with VR and AR, we're putting things on, doctors and all that kind of stuff. So How long did you have to get used to it, and what is it like for you to do the setup in the
Actually, since I do a lot of education, surgeon education stuff live, it wasn't, remember, I'm not wearing anything like we'll go over a live event. Our surgical headlight or the overhead lights actually have a camera built into them. So we're able to kind of zoom that camera in. I'm not wearing anything. We have other cameras and everything that's set up. So I think for me, the biggest thing is just the prep time ahead of time. But once I'm in the operating room, the experience is, as a surgeon, is exactly the same as if I had, somebody visiting from and being there live, except I don't have to make sure that they're well taken care of, or if they're distracted or they can't touch them. So it's actually more anxiety provoking to have a physical person in the OR than it is in this thing. Like I said, so one of the ones we did was with my good friend and mentor. His name happens to be Randy Betts, and it was a continuous. He loved it. I think he didn't really want to send the headset back, but the whole time we had a running conversation, and just like we normally do, you would ask questions. He made great suggestions. I really, it was really, I walked away from that experience really feeling like that was the power of it, that live engagement, but in a way that was safe, that was appropriate. And again, I didn't have to wear a darn thing to make it happen. So that was what was really nice for me.
Wow, that's great. And so that takes the questions of, we always get the questions around, how do you sterilize it? What do you need to do when you're using it in real surgery? And you're like, no, it's not within, you don't have to keep that camera or anything within the distance of.
Yeah. So what happens, it really is, this is where I would like to, and I'm kind of looking at more, is optimizing it so there is appropriate surgeon engagement. Because like one of the things that happens with us is I think the negative part where I had with it was, again, my surgery is a little longer. One of my surgeons that assists me, he tends to look over the wound a little bit. So his head was in the way of the camera the whole time, one time, and we didn't get a lot of engagement. This was one of the events where we didn't get a lot of engagement, and nobody let him know that. And then I found out about the fact after it. So it's one of those things where the learning curve, I think, is more on just on kind of learning to make sure you're teaching to it, as opposed to changing anything you're doing in the OR. Your setup is exactly the same. Everything else is the same, but you have to be aware that it's there. Otherwise, you have your head in the way of the camera, which is less than ideal.
Well, I wondered about that level of engagement because you might have multiple doctors watching, and are they interrupting your activity? I mean, are you getting the questions fast enough, low enough?
Yeah, so I'll mute them sometimes. You can go back and forth. So if there's something going on where you're not, so live surgery in my specialty is not an unusual thing where surgeons are engaging you, and a lot of times you can manage that through somebody to moderate the session for you, where the questions come in from one person, or the other way you can do it is just muted on the time where you think. So right now the groups I've been keeping are relatively small. And they're the good news is they're all relatively high level surgeons. So it's been nice in the sense that they moderate themselves quite well. But at the same time, there's we've thought to that, and what we've thought about is in larger groups, what we may do is maintain a single moderator to control the questions as they come in, so that the surgeon who's doing the procedure isn't quite distracted by that. And that's a common way we do that.
So it's hard to see on the video because it's so small, Dr. Bailey, like that, but there is a collaborative panel where the attendees are able to be seen by Dr. Asghar, like by the teaching surgeon. But I don't know if you see that while you're doing the surgery or not. Like, do you see the attendee, or is that for the attendees to see each other? You know what I mean? There's like a list of, maybe Dr. Bailey, that's, I don't know.
I think you can see it. I don't know if that question was directed to Dr. Bailey, but
either one.
But you can usually see it on the monitor. And usually right now what we're having is somebody to a tech essentially to manage it in the live setting. So there is one physical person that's there. The nice thing for us has been it's been this essentially the same person who's helped us kind of develop the system. So for our institution, so it's worked out fairly well. But she's able to kind of tell us who's on, who's not, and things like that. So
yeah,
and
so
if,
the
you know, like
remote
live,
attendee can put their windows anywhere they want. Dr. Bailey
Yeah,
mentioned
yeah.
that. But you see it on the monitor if you want to, but you got a moderator in there with you. So, okay. So we also want to ask about funding. And so maybe this is to Dr. Bailey, but in order to get something that's usable in the OR, first off, did you have to get FDA approval for this? I'm not sure that you would. And can you talk about that for just a minute? And then the other is the money thing, like getting something into the medical industry that uses VR can be quite the journey. So if you want to talk about that briefly, and then I'll open it up to questions from the audience too.
Sure. So I'll preface this by saying we are strategic partnership funded. So far we've been raising money. We've closed a Series A. And so we're using that to help develop and validate the system. Additionally, right now we're in the process of applying for other funding through grant agencies or similar type avenues of funding in order to do even more research on this. So that's something that we're very interested in doing is continuing the research to validate the system. And then the FDA question. So our system is not classified as a medical device by the FDA. So we work with a legal team who has expertise in FDA approvals. We've worked with them and our system has not been designated as a medical device. We're not manipulating anything. We're not touching the patient. We're not even in the sterile field. So in terms of FDA, right now, we're not in that realm of medical device. If things change with the system, we might work again with a legal team to determine if we change our FDA designation. But right now, we're not a medical device.
So in that area, if you moved your future, which I would ask about where this is going before we go into the questions from the audience. We have some great ones. But what's the future of this? Is it like remote consult to help someone do surgery? Or is it always in the training? So I think I'd love to first ask Dr. Asghar where you put on your future vision hat and where do you think it's going? And if you know of any barriers to heading there, I'd be interested in it. Where do you think this kind of tech is going?
So there's a couple parts to that. So in the live surgical realm, I think there's a possibility of doing proctoring and reverse proctoring for procedures. And I think you are already starting to see some of that. I think that is hugely helpful, especially with adoption of new technology. So when widget A comes in, right? Again, there's always a barrier to adoption for that widget. Again, so your experience in the lab, you visited Surgeon X, but sometimes you still don't get the adoption until somebody can kind of push you over that. And having somebody there who is can walk you through the process of, hey, you're doing great, and just being, even if it's moral support, is being present is something that I think has a huge value to actually the medical device industry. I think that's where it is. The other aspect of it, and this is kind of the remote areas, kind of what we alluded to, rural or potentially even international, where they don't have the same educational exposures that maybe we have here. So the being able to convey and deliver this to them in a meaningful way, I think has a huge positive potential. Again, it's one of those things where as the technology becomes more ubiquitous, a lot of times it's going to run in all sorts of directions that we don't even anticipate. But I think early on, I think the easier one was going to be the proctoring, reverse proctoring, and then the accessing, access for rural areas, rural physicians and stuff like that.
Yeah. Dr. Bailey, maybe you could comment just on, so the equipment that goes to the remote learner is just a headset? Like, what's that equipment that goes to the remote learner?
Yep. So they are just sent an untethered headset, and that was another thing that was a goal, was to make sure that it was a system that they didn't have to have a high-powered computer or some other system to hook into. They just received the headset and the instructions for logging on to the live event. And we've hopefully designed it as intuitively as possible. And our user testing has supported this, that it's user-friendly. They get the headset, they put it on, they attend a live event.
So we had a great talk from the FDA, and we had an expert that came from the FDA in headsets and in vision. And so is it a custom headset or is it a commercial headset?
Right now, we're actually using the Oculus Quest 1 because that was the first untethered headset that had the resolution and the frame rate and the necessary specs for being able to stream live video with our software. But right now we're just using commercial off-the-shelf untethered headsets. Exactly.
Well, I don't want to make the audience upset, so let's get into some of the audience questions here. So the first question from Jeff Bale is, what's the tech stack behind the low latency, such a low latency?
Sure. Just going to preface this. My background is human factors and not on the software development side, but we do have a mathematician on our team that actually helps with making sure that our algorithms for compressing the stream, dewarping the stream are all as efficient as possible, so that we're sending in as low latency as possible. So I think that other people on my team can address the tech stack specifically.
Do you think is this special sauce? I mean, is this patented, or is this something that you can discuss?
Yeah. So it's patent pending. So yeah, so we can get more into that with the tech team.
So that's pretty interesting. Okay, and so the next one is, how do you see volumetric video playing a role in the future? That's from Bob.
Great question. I am very excited about the potential of volumetric capture because I think that there's so much potential there. As of right now, I don't think it's there yet for low latency streaming, which is, as Dr. Asghar was pointing out, that really is important, that communication. So I think that volumetric capture is very exciting, and I want to see it, and that I think is the future in a lot of ways of a lot of the XR. As of today, it's just not practical yet for this purpose.
Cool. And I think this question might go to you, Dr. Asghar. The next one's asking about spatial audio recording, and would that be useful? And if you're doing that, to Dr. Bailey, but what do you think about the notion of really understanding the audio within the training? Is that something that's important? And what are you doing?
Well, I think the audio in my subspecialty may not fill as much of a role. I think, but the spatial orientation of knowing where things are in relationship to one another is very, very important, because how the room is set up, how the things are engaged. But the audio, I think, is at least in my subspecialty, probably doesn't have the importance.
Dr.
But
Bailey,
I think it just depends on the technology.
Sorry, yeah. Yeah, go ahead.
I absolutely agree with Dr. Asghar. It depends on the situation. So we have tested different types of microphones, directional microphones, room microphones. We've looked into, we actually do have the stereo sound microphones that we've tested in the lab or in our office. I don't think for the specific purposes, the use cases that we've done so far, that it would have added much, because they are so focused on what the surgeon is saying. So we really want that microphone on the surgeon who's giving the instructions.
So then from my friend and colleague, James, he has a question about ethics and consent. And I wonder if there's, he's asking, what have you had to change or address during the ethics of privacy and consent of the person seeking medical services? Has anything changed there? I mean, I'm sure you were already receiving that prior if someone attends a training, but do you want to speak to that topic? Maybe Dr. Asghar, I think. Yeah, or you.
Yeah.
So for us, I think we've been very cognizant about protecting patient privacy in the sense of having any PHI data, patient health information, visible. We do obtain informed consent for all of our patients ahead of time, so they know they're participating and involved in the thing, and that's par for the course for any live event that I do. You know, a lot of times we make it as much of a collaborative thing and of understanding that what the patients are going to be involved with. But I think it's important, critical, that that patient be aware you do all the appropriate things to protect their PHI, but the patient be intimately aware of what's going on, because I think that usually keeps you out of any ethical questions or concerns.
I can share with the audience that I'm working in the area of VR with heart surgery prep, and as long as there's no PHI, it doesn't require consent and other things like that. So as long as there's no way to tie it to a human being of any kind, then that seems to be viable for sharing.
Yeah, I think that our approach has been more on the conservative side, in the sense that and it's one of those things where it does be in an odd way, it is a little bit of a marketing thing. Is like, hey, we're an educational institution. We're going to utilize this opportunity not to even help you, but we're going to help other people by teaching people around the world. And so we kind of use it on two fronts. But like at our institution, we've made the decision to make people aware of what they're going to go through.
Now, and are you recording this, or is this something that they're only allowed to attend live?
So we're not recording at this time. We don't have plans.
Okay.
So this is a live session that they have to register for. They have to pair the headset, so they only have access if they have registered for the event. So there's a process in which we work closely with the surgeons in the hospitals on this process, and we're definitely conservative.
Yeah, but very interesting when you think about tracking a library of experiential training, right? Around if you recorded it. So some of the stuff I do is working in that path, to record so that you can do remote replay in VR. So it's interesting, that area. And you're not heading into that, Dr. Bailey, yet as a company, or?
We don't have plans to do the recording. I mentioned a little bit in our presentation why that is, which there are benefits to recorded VR video, but there are benefits to live. And right now, the live and low latency is the hard part, and we are doing that. And so we're focusing on what we're able to bring to the table,
Right.
as opposed to what's already out there.
So we have a question from Kimberly, and I think that Dr. Asghar already talked about this a little bit, but has COVID hindered the VR training? So you may want to take that one on again. I think I heard you say that it kicked up interest, but what do you say to this?
For us, it's actually accelerated the process, because from again, being at an institution where we have a lot of visiting surgeons, them not having access to the visiting surgeons not having access to the educational opportunities, it's a big takeaway, right? And it's also a big takeaway for the medical device industry as well. So it really has kicked up a lot of interest. And so if anything, I think it's also, as we emerge from the COVID crisis into a kind of a post-COVID environment, the potential cost savings and things like that are something that is really being looked at intimately, because of the fact that it is safer. The potential for, if all works well, if the potential for the technology to be safer, more efficient for the patient, and because of having, we know OR traffic leads to issues, as well as cost savings for the physician and the medical device industry. I think this has a good amount of legs on it. So I think the COVID situation has accelerated it, but I think it was headed down this path naturally anyways.
And it might be here to stay, right? So here comes
Exactly.
COVID, pushed it, and it was time for this anyway, kind of thing, like that. Yeah. So we have a couple other questions. I know we're hitting the hour, folks, but I think both of our doctors can stay for just a minute. We got two more questions, if that's okay. At the high level, we have a question coming in from James Liu. He's saying this is such an overlap with what they're trying to do with live streaming with the HoloLens 2. If it's a fair observation, can you please compare and contrast these two technology use cases? And I know Dr. Asghar has already talked about the fact that he's not wearing something. So that's a huge differential right there. But let me leave this with you, Dr. Bailey, maybe as a first stab.
Sure. Yeah, there is a lot of, so as I said very early on, we're kind of in the middle of this spectrum from AR and VR. So it is a live video, so you get that experience, but it's a remote location. stream to VR equipment, VR headsets. So I think conceptually we're a lot closer to augmented reality, but people, if we say AR, they think AR glasses, which we're using VR hardware, which in a lot of ways has, it's a little bit better in terms of resolution and field of view at this point in time. I think as AR and VR technology hardware develops, I think we're not going to see this distinction where there's people are distinguishing between AR and VR so much. So yes, we're similarly conceptually similar to AR. We're using VR technology. There's some overlap too in being able to stream to AR devices. But I think what's unique, or not unique, what's different from the AR devices is you're not seeing an actual room in front of you. You're not seeing your office in front of you. You're seeing the operating room or the bioskills lab of somebody else. You're in a different location. So
I just think that's the deal, right? It's so powerful that it's like you're really putting them there, and AR would not do that. And so that AR would put the rest of the world there with them, right? You know, so you're putting the remote person with the VR where Dr. Asghar is. And so that's why the setup is this way. Yeah,
exactly. And you're limiting the distractions of the world
right.
around. You're not seeing your office. You're
exactly.
seeing.
All right, so we have one more from Joe, and the other ones we've kind of covered on sound. So he says, do you have an existing or planned use case for intersecting surgical surgical pathway like or surgical pathology, specimen grossing? So he's asking about pathology, I'm sorry, and the use of this use case. And do you have any like plans, or are you doing use cases in that area? That might go to you, Dr. Bailey. I don't know if you know all about all the different use cases that are starting to use this.
Yeah, I don't think so right now. So far, we've mostly focused on
great question,
because that is definitely an area that this is very useful in at this moment in time. So I think that there are definitely a lot of other use cases out there that we could explore. But right now, we're focusing on where we can do good at this point in time.
All right, so thank you both so much, and I just want to give you last word. If either of you wish that you could say something that you didn't get to mention, or somebody that didn't ask you a question or something like that. Is there any topic that we haven't covered? If not, I'll close it out.
I'm good.
Probably not. You're good?
No, enjoy.
Are we all doing good? All right, so I want to say thank you very much to everybody, and thank you for coming. This may be the last webinar for this year, I'm not sure, but I wanted to show we have a new community that everyone is invited to go to the Slack, and you can see that on Share More. So it's https://bit.ly, and it's MedVR Slack. And so you can find that channel if you want to keep talking about this. It's very new for us, so we're going to roll more into it over the next year. And as I mentioned at the beginning, we've done 12 talks this year, and you can go see all of them. And some of the talks, if you're really new to this, at the very beginning, we had a couple of talks in a row that talked about what is AR, what is VR, and what does it all mean. So, well, thank you guys very much for rounding out the year. This was wonderful. And I'm going to call it. So thank you, everyone. Thank you for the audience, and have a great day and a great happy holiday. Thank you for your time.